With this, I invite Dr. Arya to discuss on the red flags in optic disc edema. Dr. Arya works as an associate professor at Arya Trivandrum. Welcome, Dr. Arya.
The outset, let me thank KSOS Scientific Committee and also Dr. Divya Alex for this opportunity. My topic is swollen disc hidden danger, red flags in optic disc edema. So optic disc swelling, it is a non-specific response to injury to the anterior portion of the optic nerve. And the mechanism, it is due to exoplasmic stasis, and it can be due to various causes like ischemia, inflammation, compression, or infiltrative lesions which produces the optic disc edema. Now, it can be due to papillary edema. When do we say it is papillary edema? When there is bilateral disc edema along with raised intracranial pressure. Other causes of optic disc edema can be optic neuritis, ischemic optic neuropathy, compressive optic neuropathy, demyelinating lesions, hereditary, or it can be due to systemic conditions like malignant hypertension. So, starting from the history, what are the things which help us to reach a diagnosis? First and foremost, ask the patient about any pain on eye movement. It's highly specific for optic neuritis because 90% of typical cases, the patient will be saying that there is pain on eye movement. Whether any history of headache and tinnitus is present, because pulsatile tinnitus or a whooshing sound and morning headaches, they are suggestive of raised intracranial pressure, producing papillary edema. Any history of jaw claudication, pain on chewing, scalp tenderness, or weight loss, always think about GCA, that is giant cell arteritis. Ask about any transient visual obscurations. And progressive loss of vision suggests always compressive lesions rather than an acute vascular or inflammatory event. So the red flag is that if the age of the patient is more than 50 years and there is a new onset of headache plus visual loss, always think about giant cell arteritis until otherwise proven. And you should immediately send for a ESR or CRP. Now coming to the examination part. What are the things that you should assess to reach a diagnosis? And visual acuity in the early stages of papillary edema, it is usually normal. And severe loss of visual acuity you get in ischemic, neuritis or compressive lesions. Coming to color vision, the desaturation will be more in an optic nerve dysfunction than a macular lesion. And RAPD will be there. Relative afferent pupillary defect or a Marcus-Gunn pupil you can see in a unilateral disease. And fundus, if there is a macular star, it is more suggestive of a neuroretinitis. Now coming to the differential diagnosis, raised IC intracranial pressure papillary edema, it's often a bilateral disc edema with preserved visual acuity in the early stages, but it requires urgent neuroimaging. Ischemic lesions such as NAION or AION, it's a vascular etiology. The patient present with sudden painless vision loss and the field defects you can see altitudinal defects. Optic neuritis, demyelinating lesions, you should always think about other systemic disease like multiple sclerosis, MOGAD and NMOSD, and pain on eye movement is a key factor there. Compressive lesions, slow progressive lesion, proptosis will be there, and in fundus you can see the opticociliary shunt vessels. Neuroretinitis due to Bartonella, syphilis, Lyme's, you look for the macular star appearance in the fundus examination. And always, you should rule out a pseudoedema, that is a drusen, optic disc drusen, which may produce the appearance of an optic disc edema. So papillary edema, the key features in fundus examination is that there will be obscuration of vessels at the disc margin, patterns lines can be there, hyperemia and venous congestion. Usually it preserves the central vision in the early stages. So an emergency MRI brain is indicated. Now this is a Frisson scale which helps us to grade the optic disc edema. In grade 1 there will be obscuration of nasal border of the disc, and finally when you reach the grade 4 or 5 there will be obscuration of all vessels on the disc, and grade 5 you can get the Champagne-Coke appearance also. So from grade 1 to grade 5. Now how to differentiate pseudopapillary edema? It will be having irregular margins, that is a lumpy-bumpy appearance. And the other important feature which helps us to differentiate is that vessels will be remaining sharp at the border. In the other thing, the vessel will get obscured. That is a very important feature which helps us to differentiate a pseudo-papillary edema from a true papillary edema. And SVP usually will be present in a drusen, absent in papillary edema. And once you do the ultrasound B scan, you can see the highly reflective lesions, that is a calcified bodies in a drusen. And OCT will be showing a hyporeflective core in drusen, whereas in edema there will be the lacy V pattern. So this is an autofluorescence picture of an optic disc drusen. And what are the other causes of pseudopapilledema other than drusen? They are the tilted disc, myelinated nerve fiber, congenitally small optic disc, and PHOMS. Now, optic neuritis, it typically affects the young females, usually in the 20 to 40s. There will be subacute unilateral vision loss. 2/3 will be retrobulbar and 1/3 is papillitis. And bilateral involvement and severe loss or a painless onset suggest NMOSD or a Mogart group of diseases rather than the typical multiple sclerosis. NAION, it's due to the infarction of the short posterior ciliary arteries. And what are the risk factors? Disc at risk, that is a small crowded cup, hypertension, sleep apnea, nocturnal hypotension, and also patients on PDE5 inhibitors. So that is the relevance of asking any history of drug intake in such patients. There will be sudden painless vision loss, usually on waking up. The inferior altitudinal field defect will be there. Next, giant cell arteritis, which should be considered as an ophthalmic emergency, the chalky white pallid edema, and profound visual loss will be there. Vision will be usually hand movements or counting fingers, history of jaw claudication, and we should not wait for a biopsy to treat the patient. IV methylprednisolone should be started at the earliest. Why? Because there is chance of involvement of the other eye also. And compressive optic neuropathy, usually in meningioma, glioma, etc. And usually proptosis or resistance to retropulsion will be there. And on fundus opticociliary, shunt vessels can be present. Now, this is a chart which is comparing all the three features which I have already explained. Now, the visual fields. In optic neuritis, there will be a central scotoma, altitudinal defect in NAION, enlarged blind spot in papilledema. Compressive lesions usually produce a junction scotoma, and secocentral or centrocecal scotoma is in toxic or nutritional. And once you have a unilateral disc edema, first look the age of the patient. If there is pain on eye movement, yes, it is a typical optic neuritis. Otherwise, it will go into the category of atypical or neuroretinitis. Age more than 40 years, always ask for jaw claudication, scalp tenderness. Yes, then it is an ophthalmic emergency, as I have already told. Bilateral disc edema, before jumping into conclusions, always check the BP of the patient, because high BP, malignant hypertension can also present as a bilateral disc edema. So before doing a fundus examination, record the BP of the patient, even if the patient is not giving any history of hypertension. Now going into some cases, this was a 50-year-old female who presented to her OPD with headache and mild blurring of vision of 1 week duration. BCVA was 624 in both eyes. She didn't give any history of comorbidities, but we looked the BP, it was 130/90, and the anterior segment examination was within normal limits. This was a fundus picture. You can see there is bilateral disc edema, and you can see a hemorrhage also close to the optic disc. We ordered for an MRI, and neurological evaluation was also done. There was no obvious abnormality in the brain parenchyma, but there was bilateral prominent perioptic spaces seen, and which could be suggestive of idiopathic intracranial hypertension, and the patient was started on TAP Diamox. This was the OCT. Next is a 56-year-old male patient, diabetes of 7 years duration, and defective vision noted in the left eye of 3 days duration. Vision in the left eye was 618. Anterior segment examination was within normal limits. So fundus, you can see there is a unilateral disc edema. We did the field, I don't have the field pictures. He was having an altitudinal field defect, and he was diagnosed as an NAION. 50-year-old male patient with prominence of eyeballs of 6 months duration, defective vision of 1 week, there was loss of weight, and he was diagnosed to be hyperthyroid. Bilateral axial proptosis was there. BCVA was 612, and the color vision was found to be defective. And we did a dilated fundus examination. You can see the compressive optic neuropathy along with the retinal fold. So that is the importance of a fundus examination of a thyroid ophthalmopathy patient. Now these are the red flags, as I have already told. Headache, vomiting, nausea, focal neurological deficits such as raised ICP, space-occupying lesion, MRI is indicated. Systemic signs, always rule out. Scalp tenderness, jaw claudication. Whether there's fever, rash, lymphadenopathy, it goes into an infectious category. Always look for neuroretinitis also. So OCT, RNFL, a B-scan ultrasound to differentiate an optic disc drusen, MRI brain. Now, what is the take-home message? Always, history is the king. Pain on eye movement, age and speed of onset. These are most powerful differentiators before you even look at your disc. And true bilateral papilledema is an intracranial pressure issue unless proven otherwise, and imaging is mandatory. And in an elderly patient with disc edema, ask about jaw claudication or the ESR CRP platelets. and differentiate your drusen, avoid unnecessary lumbar puncture. Thank you.
Thank you, Dr. Arya. That was an informative session.
Thank you.
What about this acute optic nerve edema in a child or a kid? Because once in my OPD, I got a 12-year-old girl. So her main problem was lethargy. So her parents were doctor shopping for the past 6 months. Everyone was telling it's her puberty hit. Like mood swings, it can be something like that. Nothing great of me, but as retinal surgeons, even if the patient comes with itching, we dilate and see. So at that time, the patient really had literally bilateral huge disc edema. So how important, and the patient had IIH actually. So every symptom was misread as that puberty hit. So how important is it when a kid comes to you and you do a fundus examination?
In kids, usually optic neuritis can present as an infectious cause. The kids can present as a bilateral disc edema. This optic neuritis, infectious cause you have to rule out. Also, whether the child is obese and idiopathic intracranial hypertension should also be ruled out. Whenever you see a bilateral disc edema, you have to do a neurological evaluation and imaging is very, very mandatory. Then only we can proceed. I feel it can be due to an optic neuritis or due to IIH.
One more point I want to highlight. Just doing an examination is not enough. Take a photograph always, because sometimes we miss some very subtle finding, like what doctor just now highlighted, that in disc head drusens, there is vessels will be straight, there will be no hemorrhages, no other signs. So this is, we just do an entire ophthalmoscopy in a busy clinic, we might diagnose it as a papilledema or optic neuritis, and we can start the treatment advice MRI brain, which is overdoing for the patient. So always when you see any suspicious findings, take imaging, especially in a busy OPD, and correlate your examination with the imaging. Sometimes you can just find out subtle findings just with the imaging in addition to your examination.
Thank you, Dr. Arya.